The next speaker is Jeff Lackner. Jeff is at SUNY Buffalo, and he is a psychologist that really has a lot of expertise in behavioral medicine, especially developing simpler, shorter types of behavioral medicine to be used in conditions like irritable bowel syndrome. He's going to be talking about irritable bowel syndrome, but he's done a lot of work in eating disorders, and I think he probably considers himself more generally to be a behavioralist. So, Jeff?
Thank you. I first want to thank NIH, who's provided funding over the past 30 or so years, and including our current CBT grant for pelvic pain. But grants don't come off trees, and the work that I have done would not be possible with the nourishment of the roots, which come from the elements of people like Dan Claw, Dave Williams, and Chris Veasley, whose work has been foundational to the work I'm going to be presenting today, and I really want to thank them. As you'll see, it's informed how we think of nociplastic pain conditions, and kind of allowed us to build upon that. In any case, I want to introduce you to Ashley. Ashley is a 37-year-old Caucasian married female with 2 kids. She had chief complaints of abdominal pain, diarrhea, urgency, and she had GI symptoms her entire life. They worsened in her late adolescence, and when the abdominal pain grew more uncontrollable and unpredictable. She attributed her symptoms to random foods, hormone stress, and taking a lot of Imodium. She had no prior surgeries, but she did have a history of back pain following a rowing injury. Her family history was negative for GI disease. With respect to lifestyle history, she exercised twice a week, she ate fruits and vegetables 4 times a week, and she was a social drinker. At pre-treatment, her IBS symptoms were moderate to severe, and her predominant bowel symptom was diarrhea. Her average pain was 5 of 10, and her worst pain was 7 out of 10 on the numerical rating scale. She had 6 problem pain days a week that are 3 or greater of 10. Her symptoms imposed significant quality of life, and while psychological testing was normal, she described herself as a nervous person prone to worrying about my stomach. Her symptoms had been refractory to dietary medical treatments. Diagnostic testing was negative for organicity, and she met Rome diagnosis for IBS before she was referred to my clinic for CBT. Like many COPCs, our understanding of IBS has evolved over time from a largely peripheral problem that emphasized abnormal motility to visceral sensitivity to seeing IBS as a problem in how the brain and gut interact. So we now see IBS as a problem of dysregulation of the brain-gut axis. And while alteration at any level of the brain-gut axis can influence gut motility, visceral sensation, and intestinal secretion, there are multiple lines of evidence which accentuate the importance of central factors in the onset, expression, and persistence of IBS. I'm going to be talking about one line of evidence, which is the empirical validation of behavioral treatments. CBT is believed to relieve GI symptoms by primarily modulating the central components of the brain-gut axis. For those of you who are not familiar with CBT, I want to just kind of briefly introduce what it is, because I know there's a broad range of people with experience. It's a specific class of psychological treatments that's really designed to help change how people think and what they do. It's brief, it's 3 to 20 sessions, it's structured, it's present-oriented, it's scientifically tested and found effective in over 2,000 studies of many different mental and physical health conditions, including IBS. Importantly, it serves as the basis for many chronic disease management programs. including hypertension, diabetes, and obesity, and so on. CBT targets interactions between how we think, feel, and behave in specific situations. So the notion is that thoughts, feelings, body sensations are connected and can affect one another. So thoughts influence emotions, which influence body sensations, which influence behavior, and then influence thoughts. That relationship is interactive and reciprocal. Let's go back to Ashley. Ashley, who is a photographer, has a photo shoot. The thought is, what if I need to use the bathroom? That triggers a sense of apprehension, stress, keyed up, physical sensations of tension, urgency, stomach and knots, and she calls to reschedule, which is a form of behavioral avoidance. The empirical validation of CBT for IBS was in many ways cemented with the IBS outcome study, of which I was the project PI. This is an infographic which kind of captures the primary outcome study as well as the long-term follow-up. And we recruited 460 adults with moderate to severe IBS, randomized them to 3 conditions, 2 of which were clinic-based CBT, 1 home-based CBT, and education and support. And you can see that both the CBT condition yielded improvement in symptoms of about 64 to 68%. By comparison, FDA-approved drugs are at best 40%, some as low as 14%, double of the placebo of 7%. But the efficacy for drugs is for FDA-approved drugs is comparable to what we see in a active control. So what are the technical components of CBT for IBS? I'm not going to go into the detail, but I do want to spend some time talking about the cognitive components because it really is an innovation of ours and kind of maps onto our conceptual model. And to that extent, I'm going to be talking about both the cognitive flexibility exercises that we use as part of our worry control module and flexible problem solving, because I think it captures something about the cognitive processes underlying nociplastic pain conditions. This is a figure from a recent article in Pain, which captures illustrates the cognitive behavioral conceptual model, and it accentuates our notion that IBS and perhaps other types of nociplastic pain conditions are characterized by a rigid cognitive response style, characterized by cognitive biases and a flexible, inflexible problem-solving style that's predisposed to control-oriented, achievement-oriented, control-focused way of solving problems. So, I'm not really good at this, but you see the cognitive, I can't. I'm Jewish. So this is Ashley's problem-solving days, problem pain days at week 1. She had 6 problem pain days, and the initial one of the modules was worry control that is designed to improve cognitive flexibility. And the goal here is to identify how thoughts disrupt brain-gut interactions and how cognitive biases, when unhelpful, can intensify GI symptoms. The goal is to increase cognitive flexibility through two strategies, one evidence-based logic and the other decatastrophizing. It really focuses on one cognitive bias, which is overestimating the risk of threat, captured in what-if thoughts. And there's some pretty interesting cognitive science research on this as prediction error or expectancy bias. This is a home exercise of Ashley, and you can see that she's asked to write down what a challenging event was, and it was her first photo shoot. And her immediate thought was, I'll worry I'll get diarrhea and I have to leave or use the bathroom. She's then asked to then write the initial odds in the heat of the moment. She says 100%, and she learns to then actually obtain evidence to support that, of which she has none. If there's none, then she revises that probability. She says 2%, and in keeping with social learning theory, she then kind of asks, does it happen, as a way of updating her prediction capability. At week 5, her problem pain days dropped to 5 a week. The other cognitive error that we focus on is overestimate the costs and consequences of adversity. That's captured in an if-only thought. So the focus is not on the future, like a what-if thought, but on the past, which is, if only I'd done that. And so the goal here is to kind of shift gears to not focusing on the costs or consequences of adversity, but on an ability to endure, to cope, to work around challenges. This is what cognitive scientists refer to as an interpretive bias. And I think this is a nice slide which captures the home exercise. I have a family birthday event, daughter spilled gluten onto the meal. I had to remake the meal, I'll be late. So you can see in the second column the focus on how bad the event is. I'm upset, I'll be late, I feel guilty, I feel I'll be judged, I'm very distressed. And so the goal here is to kind of shift gears, to move the person not to focus on the adversity, but on strategies that kind of move beyond their focus on the adversity and whether they can endure it. I kind of liken this as living in Buffalo and being growing up in Denver as what happens when you accelerate when you're stuck in the snow. Your goal is to shift gears, not to put the accelerator down. So is it time limited? Yes. Is it manageable? Yes. Is it distressing? Yes. Acknowledging, validating the emotional upset of the event, but also kind of contextualizing it in light of someone's ability to handle adversity. Can I let go? Do I have a choice? Is it useful, and is it worth developing a problem? And then you can see that rather than digging deep and focusing on how bad it is, the person is able to kind of shift gears in a way that dampens the unpleasantness of the situation, both emotionally, physically, and behaviorally. And you can see after week 8, her problem pain days drop to 3. This is a strategy that we developed in our first grant with Ed Blanchard in 2000, and it's flexible problem solving. It's really designed to help deploy effective coping strategies for containing the emotional fallout of controllable stressors or solving controllable ones. And the goal is to teach people to choose an optimal coping response based on more accurate reading of situational cues, particularly controllability events. This is what social psychologists like George Bonanno at Columbia refer to as context sensitivity. This strategy came to my mind after reading a study in health psychology by C.C. Chang. And I think it's a wonderful study which shows how functional GI patients and other people who have pain have a non-discriminant way of solving problems. Let's go to the first slide, the bottom slide of healthy controls. You can see that with healthy controls, that when something is controllable, the blue bar, they take direct action. Whereas if something is uncontrollable, they accept it. With people who have functional GI problems, look at the direct action, regardless of whether it's controllable or uncontrollable, they take direct action. Which means the problem is not to brainstorm your way through a problem, as is the prescription for most traditional problem solving, but to get them to be more contextually sensitive. Let me show you what I'm talking about. Problem solving in healthy individuals, they identify a problem, they ask, is there anything I can do about it? And if it's yes, they adopt problem-focused response. They emphasize resolution, they plan, they approach, they take action. They basically try to fix a problem. If it's uncontrollable, they say no, or they automatically assume it's no. And the goal is to weather it, to handle the emotional unpleasantness of problem. They accept, they resign themselves to it. They enlist support. They might talk to their best friend, their partner, and so on. They decatastrophize. They kind of let go. They might reduce physical tension, exercise, muscle relaxation strategies, take a walk. But with IBS patients, regardless of whether something is controllable or not, they try to fix it. That leads, what we know about the perseverative thinking, that leads to worry, rumination, acceptive avoidance, distress, insomnia, and symptom amplification. I want you to think about that in light of what Dan Claw said before, in terms of symptom awareness, in terms of insomnia, in terms of other types of cognitive arousal and impaired problem solving. So the goal here is to get people to actually identify accurately the control appraisal and to calibrate that to what they can do or what they can't do. It rounds out their problem solving toolbox in ways that's really, we feel, important. I'm not going to really get into this. Another component is controlling core beliefs, which are schemas thought to underlie negative thoughts, illusion of control, perfectionism, expecting approval, before finishing off relapse prevention, which is really designed to help people sustain gains after treatment ends. And as you can see from that infographic, the type of persistence or durability and lack of decay in CBT is pretty remarkable through 12 months. I'm not sure that there's any other CBT for pain trial that has ever showed that. Not that the bar is pretty high. Just saying. So in this, when Ashley finished, she had one problem pain day. When I asked Ashley to give me ask her permission for a slide, she actually sent me a couple of pictures. I blurred them out out of courtesy, and this is what she wrote, and I'll give you a couple of minutes to kind of read that. But Ashley's not the only one who responded. This is a New England Journal of Medicine article in 2008 by Emery Mayer, where he identified our protocol for CBT as one of three treatments of any type that was efficacious. And CBT seems to be the only treatment that cuts across all different types of bowel type in terms of empirical validation. This is a study that was in gut, identifying self-administered minimal contact CBT as evidence-based choice. And one of the interesting things, as many of you know, is whereas the CBT for most pain disorders has a rather modest, if not disappointing track record, analgesic track record, CBT for IBS has a much more robust impact on pain relief. But what we were kind of interested in was also seeing if CBT is really has effect on whether we saw a spillover in other types of nociplastic pain conditions. And so we looked at other co-aggregating pain conditions. We added GERD and non-cardiac chest pain, which I think actually, if I want to nominate a disorder to the COPC, I'd put non-cardiac chest pain, because both GERD and non-cardiac chest pain have, to some extent, a centralized component. And we were interested in whether how the treatment response for targeted treatments, for target disorders, compared to untargeted. And as you can see, in some ways, our untargeted effect sizes for the pooled treatments was some ways more impressive than the targeted, which is what you'd expect if we're talking about a transdiagnostic treatment for nociplastic pain conditions. Before closing, I want to kind of then talk about what the illness burden is that comorbidity imposes on COPCs. And we're doing this in the context of our EPIC trial, as I mentioned before. And we were interested in what the most common COPCs were. Migraine, past depression, which is really interesting. I don't think anyone has really talked about the extent to which past COPCs impact current COPCs. Chronic low back pain, IBS, tension headache, insomnia, GAD, somatic symptom disorder in DSM, TMD, and painful endometriosis. But for the COPC patient, comorbidity is more than a bar graph, background noise, or a nuisance variable. And I think Chris Veasley's work really captures that. It helps define their day-to-day illness burden. Last week I saw a patient in our pelvic pain study, and this was a homework exercise that one of the last things they do when they fill out a Venn diagram that captures relevant biological, psychological, and social factors that bear on their day-to-day burden. This is really messy. I don't expect you to actually decipher this. In fact, that's the point. But I will say that when you look at what this person said, back pain, stress headaches, a headache, hyperalgesia, insomnia, mood, anxiety, hopelessness, and sadness were things that really impacts the day-to-day burden. So we were interested in our study, our current pelvic study, looking at what the most common dyads were. Not just, and I think Dan talked about that, or briefly alluded to that. Of 666 theoretically relevant possibilities, including 37 total comorbidities, 9 COPCs, and 28 psychiatric, these were the most common dyads. And you can see that past depression, migraine, chronic low back pain, tension headache, generalized anxiety disorder, insomnia are really big players. So this is the unit increase and we looked at this across multiple endpoints, and I'm not going to go over each endpoint. I picked 2 endpoints. One is fatigue, and you can see that that the numbers on the slant are the unit increase in fatigue symptom severity associated with a single comorbidity. So for example, with chronic low back pain, we see the fatigue scores will significantly increase by 2 points if the pelvic pain patient has chronic low back pain. If they have multiple comorbidities, for example, if they have migraine and IBS, fatigue scores will significantly increase by 2.64 points. We're not going to get into details. I'm happy to send this slide deck, but you get the idea. For distress, these are the unit increase in the BSI Global Severity Index. So we also looked at dyads. So the BSI-GSI score will significantly increase by 9 points if the person has tension headaches and chronic low back pain. But you get the idea that this really is a nice way of looking more detailed in what are the COPCs that not only co-aggregate, but impose the greatest impact. Interestingly, we saw relatively less impact on the index pain. Before closing, I want to kind of go over one last data point from our pelvic pain study, and that is looking at healthy days, which is a measure that the CDC uses to look at health-related quality of life. It's really simple. Asks people how many days in the past 30 when your physical and mental health were good, and this shows you an infographic on that. The incremental increase in unhealthy days in the past 30 days when physical or mental health was not good was particularly significant in chronic pelvic pain patients who had comorbid mental health, migraine headaches and chronic low back pain, and that's the light green, and tension headache and chronic low back pain. If they had a past history of depression and GAD, they had 9 unhealthy days, whereas the first group had 5 unhealthy days. What is remarkable is how similar this is to a similar study, to another comorbidity study we did with a different population, IBS, with a different sample in clinical gastroenterology. So behavioral treatments represent an evidence-based option for COPCs. As a psychologist, I'm a little less enthusiastic than Dan is about CBT in general, but I think that there's certain types of CBT that are quite effective. Behavioral treatments may derive in analgesic properties by increasing cognitive flexibility. There is a need to understand which COPs individually and in combination with other COPCs and non-COPC comorbidities selectively impact health outcomes important to patients. Depression, insomnia, headache, GAD, TMD, and chronic low back pain seem particularly insidious. Future research should elucidate fundamental trends, diagnostic processes common across COPC diagnostic categories. Operating from a transdiagnostic model stands to identify and refine mechanisms common to COPCs and their effects on pain and sensory processing in a way that cultivates more effective, efficient assessment and treatments for all forms of COPs than traditional disorder-specific treatments for each COPCs, of which there are over 100. And that is really a problem in terms of furthering the schism between research and clinical work. Information processing biases, a rigid cognitive style has meaningful explanatory power beyond spatial distribution or number of CPs in understanding their mechanistic underpinnings and engineering more targeted, scalable, accessible therapeutics. And I want to just say that for us to adopt that approach that integrates cognitive science and applied social psychology, we need to make a distinction between psychiatric, which I don't see COPCs, and psychological, which integrates cognitive science and applied social psychology, which I actually feel is a rich domain data source to draw upon to understand how the brain makes sense of symptoms. And I think this is a study which clearly doesn't have everything, so don't yell at me. But I only have so much space. That I think it kind of integrates our understanding of COPs, of nociplastic pain, as a way of informing low-intensity behavioral treatments for refractory disorders like pelvic pain and chronic low back pain. Thank you.
Yeah, one question. We have time for one question. Okay, well, you know where Jeff is now, so thanks so much, Jeff.